Dr. Lasker?
Okay, I think the next presenter is Tania Kourtidou, who is a pediatric cardiologist. She works at the Onassis Cardiac Surgery Center, and she's a very good colleague. I think she's going to talk about, I'm not sure, would you like to?
Good afternoon. Thank you very much for the invitation, for the kind introduction. I'm going to speak about the use of CMR in the pediatric population in congenital heart disease, despite the fact that echo is a very comprehensive technique for us, for young children. I should start sharing. Okay, is that okay now? Can you see?
We can't see.
No.
I get a message that says that my screen has been shared.
Yes. Now we can see.
Okay, perfect.
Thank you.
Okay. We most of the times we use the CMR when echo has not demonstrated enough detail in the anatomy, and particularly when we would like to avoid invasive diagnostic procedures or procedures like CT that have radiation, and when we need to make really complex surgical decisions. And that is because performing a CMR is a quite disturbing process to a small child that often necessitates general anesthesia, not even just sedation. And it's quite technically challenging to us. Occasionally, we have to work without contrast when the kids cannot tolerate an IV, or we use suboptimal quality imaging techniques like free breathing sequences, or having the kids watching a movie that makes them quite collaborative, but at the same time quite enthusiastic and moving targets in the machine. However, recognizing that the CMR has ample supportive guidance for the congenital heart disease population, we do have guidelines over the past few years on how to perform standard imaging and what to communicate to the community. So we assess morphology, ventricular function, complex anatomy of the vessels. We do flow analysis, and we try to explain the physiology of the patients based on the anatomic variants. We do characterize their myocardium, and occasionally we have to do perfusion scans. The way to analyze the study and the way to communicate the information to the surgeon and the primary cardiologist does need to follow specific guidelines and taking into consideration the reference normative values that are different for kids based on their age and their BSA, or report the findings, the lesion-specific findings, according to what we call the segmental anatomy. And we're going to discuss the questions that CMR can help in congenital cases based on the above severity classification from the most simple to the most complex ones. And for that, like I said, we're going to follow the systematic approach. In the beginning, we do have to define the location of the heart in the chest and its relationship with the liver, the stomach, or the branchial cyrus. And we need to identify the structures and the particular components of the heart based on their morphology and their relationship with each other. So it is not necessary that an atrium is going to connect to the appropriate valve and the appropriate ventricle and the expected great artery. And then we try to find out for any associated abnormalities and any coexisting conditions. With that in mind, we move on shunts, and the classification is important because we need to define if the communications are within the heart, like atrial or ventricular septal defects, anomalous pulmonary veins that bring the blood back to the heart, versus extracardiac shunts, at the post-pneumonic vascular bed, such as are the pulmonary collaterals or patent ductus arteriosus and fistulas. A collateral vessel and as such, the shunt it's gonna get blood from the main pulmonary artery, and the blood that is gonna go back to the lungs is gonna be what the RV sends forward, so what you have in the main pulmonary artery, and what extra blood you get from the aorta. So that extra shunt bypasses the heart itself and it goes straight to the lungs. As such, the calculation of the extra blood, or what we call the QPQS, is significantly different than what happens when we have intracardiac shunts. Our imaging goals with shunts are to depict the morphology in detail. So, for example, when we have atrial septal defects, we need to characterize the location, the size, and the surrounding tissue, and suggest if this could be amenable for device closure or surgical intervention is the only option for the patient. So we need to define the rings around and look for coexisting anatomic conditions. For example, atrial septal defects can occur with abnormal pulmonary venous connections or an interrupted IVC or bilateral SVCs and such. And once we have defined the anatomy, then we move on to quantification of volumes and shunting, what we call QPQS. The degree of shunting is quantified based on the volumetric analysis, so comparing the stroke volumes, or we can use the velocity encoded phase contrast by measuring the amount of blood that goes through the aorta and the main or the branch pulmonary arteries. Alternatively, we can use the 4D flow. And this is a schematic of what I described earlier. So when you have an intracardiac shunt, meaning that it is an ASD, a VSD, or a vein that ends up in the right atrium, then your the blood that goes to your lung, so your QP, is going to be same to what your right ventricle is pumping out, or your main pulmonary artery is pumping out. Whereas when you have a shunt that is outside from the heart, it's like a PDA on the top of the screen. In that case, your the blood that goes to the lungs to get oxygenated is not only the blood that you get from your main pulmonary artery, but also the extra amount of blood that you steal from your aorta. And as such, your QP is your left stroke volume, and your QS is your right stroke volume. Moving on to, and in order to avoid any confusion, the guidelines, they do have specific instructions on how to calculate QPQS based on where the location of the shunting occurs. So this is a secondum septum defect, like an atrial septal defect in the middle of the atrial septum, and we can see it easily from the four-chamber scene view and the sagittal view. But in this case, the shunting occurs at a much lower level of the atrium. It's at the primum atrium, at the base of the heart, and you can easily see quite nicely with the black imaging, and depicted also with your phase contrast or your 4D flow once again. The superior sinus venosus atrial septal defects are commonly associated with partial pulmonary venous connection, and that is because it's not actually a septal defect. It's not a defect of the septum itself, but it's a defect of the wall of the pulmonary veins. So whenever you see a defect on the top back of the right atrium, then you need to look for the abnormal pulmonary veins entering into the SVC most of the times. In this case, that was a 9-year-old that she was taken to the cath lab for a small ASD occlusion, and she failed, and she did have significant right ventricular volume overload, but her shunt, the size of the hole looked really small. So she was taken to the cath lab for this hole, but then when the interventional cardiologist put the device in, there was still like ample shunting from the left atrium to the right. And what happened is that, as you can see here, these are your liver veins and then your IVC. And your IVC overrides the septum and the blood is directed to the left atrium. And here is the communication, and you have direct desaturated blood getting into your left atrium, and then directed to the right atrium through the small hole as well. There it is. With analysis of QPQS, first of all, you can see that the 4 pulmonary veins, both the left and the left here, and the right veins are both intact and connected normally to the left. And then QPQS with volumetric and PC flows analysis is more than 1. So she went to the operation room. Moving on to the VSDs. MRI, the VSDs are an indication for an MRI, and usually when they call us to rule out a VSD in a child, that rarely occurs. However, we do use it in borderline cases when we want to assess the QPQS, and we do follow the same principles as we do for the atrial septal defects. So basically assessing the location, the size, and the surrounding tissue, and see if this could be amenable for device closure, and by assessing the rings and the distance of the VSD from the aortic valve, using like a device destroying the valve. And coexisting conditions. So when you see a VSD, the next thing you do is to search for the second VSD that probably the patient has, and do your quantifications. That is a 9-year-old with a perimembranous VSD, and that's not a big of a deal. I'm not sure if she really needed the MRI. It's a very classic VSD in the close to the crux of the heart, and high velocity, so probably it is pressure and volume restricted. The left ventricle is not significantly dilated, but this 15-year-old, she did have a similar VSD like the previous girl, but look here now on her short axis sinus-staff, you can see intracavitary obstruction, and basically her right ventricle has been divided in 2 chambers, one high pressure central chamber and a distal chamber that is lower pressure, and that's what we call double chamber right ventricle, which is one of the most common complications of an unrepaired perimembranous VSD. We look at that's the location of the obstruction and FAS, and this is the hole where her entire pulmonary cardiac output is coming out of the heart. So she did have significant obstruction and she underwent surgical repair. Her QPQS was not significant in the setting of RV hypertension, of course. We're moving on to valves, and there are no significant differences compared to the adult population. So we do have to describe the valve morphology, the mechanism of stenosis and regurgitation, any associated pathology. We calculate volumes and LV mass for BSA, and that would be an indication for surgical procedure. And any anatomic variations. We do our measurements, but everything needs to explain the patient's clinical presentation. So there was an 8-year-old with systemic hypertension, and she also had renal insufficiency. So this study was done without contrast, and it was a free breathing study. As you can see, she has a bicuspid aortic valve and a dilated ascending aorta as expected, with dephasing artifact because of the stenosis in the aortic valve, and she had mild left ventricular hypertrophy and hyperdynamic function. But When we moved on her arch imaging, this is like a candy cane sagittal kind of projection. We did notice significantly hypoplastic and extended descending isthmus and descending aorta. So for an 8-year-old girl, she had only a 5 millimeter diameter of her isthmus, and that extended to at least 2 centimeters. It was significantly more, and I can tell you that this patient had a hypoplastic abdominal aorta as well. So we started to thinking about middle aorta syndrome, and now she hasn't been repaired as of now, and she's being discussed for more extensive intervention. And probably the reason why she had a renal insufficiency was also issues and narrowing in her renal arteries. Okay, and that was her face contrast. That is with 3 meters, 3.5 meters, in order to be able to know the artifact. And here's the 4D flow 3D printing model that you can tell it significantly elongated the area of the narrowing. And at the same time, she has a dilation in the ascending aorta. So she's quite complex. We'll see what we're going to do. Occasionally, we do encounter non-congenital cases. So that was a 15-month-old boy with a very dilated ascending aorta. And for a 15-month-old boy, this was a 4 centimeter ascending aorta with a normal aortic valve. And as you can see, it's not only the proximal ascending aorta, but the entire segment extended into the transverse arch and the first branch and inlet artery. And this is from the transverse axial stack. He had dilated all of his branches as well. There was a common origin of the right brachiocephalic and the left common carotid artery. He had a vertebral coming off and a left subclavian coming separately, as well as the left common coronary artery coming off the bovine trunk. This is a steer, like a T2 imaging demonstrating demotus wall. And apparently this kid had an angiitis, like an arteritis. This is what the biopsy showed. He had his root surgically resected, and that's what they told us. So that was not a congenital case, but still we need to take into consideration everything, including variations of branch anatomy. And he ended up having also brain and abdominal scanning. The surgeon did not intervene with his nominate. This is a 16-year-old with Epstein's anomaly, and as you can see, this is where the hinge point of the septal tricuspid valve leaflet is, and this is the atrialized portion of the right ventricle. And we have specific indices that we use, and we quantify the tricuspid valve regardless fraction, and that's helpful in order to guide surgical repair. But what happens in smaller kids? So this is an 8-year-old whose tricuspid valve is not apically displayed in the same degree of severity compared to the 16-year-old patient that I presented earlier, but he has way more regurgitation of his valve. And the reason behind that, so his displacement index is only about 18, borderline 18 millimeters, so borderline 18 to 2 centimeters is what we start calling Epstein's, but he has a very deformed tricuspid valve with his septal leaflet curved up and like tethered and functioning not appropriately. This is inflow and outflow for the LV, and you see the pulmonary valve that is also dysfunctioning. You don't see any of your mitral valve, you hardly see the mitral valve because of the dilation of the right atrium. He has functional stenosis of his pulmonary valve, and here's the coaptation defect of the tricuspid valve and fast, the significantly enlarged right ventricle with flattening of the septum throughout the entire cardiac cycle, not because only of ventricular volume overload, but also because of pressure overload. And he does have pericardial effusion as well. Here's the tricuspid regurgitation, and his forward flow through the valve was less than 30%. So 70% of that was the regurgitant fraction. And what I need to comment on this patient is that just because of this arrangement of the tricuspid valve that is way far from the pulmonary valve, and he's not supposed to be considered for a conus repair. So we do guide the surgeon based on the rotation of the tricuspid valve relative to the right ventricular outflow. So here that you see your pulmonary valve, you hardly see the tricuspid valve opening. That means that there's significant rotation, and then possibility, the chances of a successful operation are less for this specific operation. This was a 4-year-old with recurrent upper respiratory infections. That was done with the patient breathing freely, not intubated. He had what we call a vascular ring. So this is a right aortic arch. So IVC, right atrium, left atrium, ascending aorta to the right of the pulmonary atrium, and going backward, down in the belly, aorta, 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 and that's where it divides. So here it is. That's your right-sided arch. That's your what is going to give rise to your left subclavian artery. That's what you use to have a diverticulum of Komarel. That's a fetal structure, and the trachea that it's strangulated in between the structures. So that was a double aortic arch with part of the right arch here and part of the left arch here, and coming off to a common descending aorta. There should be, I'm going back. So this is the right arch. There is a left component of the arch as well. That used to be the ductus arteriosus, but because it's a fetal structure that regresses, that's why we don't see it. The fact that we don't see it does not mean that it doesn't exist. Most of the time it's there, and this is what the surgeon goes and ligates in the operating room. And that was another 7-week-old with a similar concern for a vascular ring. That was a feed and swaddle study. So we just give the baby a bottle, we wrap them into blankets, and we let them fall asleep. We give them a pacifier, and we just do a very quick 8-minute sequence, which is a black blood whole heart sequence. And we ended up seeing the same image here. So the right side of the vascular ring, and then the aberrant left subclavian. That was a potpourri of simple lesions and what we call as simple lesions in congenital cardiology is the situations where the segmental anatomy of the patient is the expected, is normal. So what you expect to go to the left side and give rise to left side structures, that's where it goes, and the same happens to the right side. But even a simple cardiac lesion, it can be a challenge when it's combined with other simple lesions, or it occurs with pulmonary hypertension or with other coexisting valvular situations. I'm not going to speak about the complex congenital heart disease that you guys also encounter in the adult population, because my talk overlapped with my colleague's talk last year. But I'm going to speak on quite complex situations that we do encounter in the pediatric population. And it's the $1 million question. If a patient who has a complex congenital diagnosis is going to be operated and he's going to end up having 2 ventricle repair, so pretty much 4-chamber circulation, or a single ventricle repair, which is a condition that is going to define his fate and make him probably transplant candidate in the future. So that was a 3-year-old boy with saturations in the high 80s and low 90s, who was born with what we call double outlet right ventricle, pulmonary stenosis, and mal-post-grade arteries. I'm going to go through the diagnosis in my cartoon later on. He had a central shunt when he was born, and then he was able to get what we call a bidirectional Glenn when he was a few months old. And he comes to us at his toddler years for his preoperative evaluation for single versus 2 ventricle repair. So that's a normal heart. And then moving on to the double outlet right ventricle, where you can see that both great arteries, the aorta and the pulmonary artery, are coming off your right-sided ventricle. There is a big hole, a VSD, between your right and your left ventricle. And there is also muscle, that's what we call a conal septum, between your big arteries, your aorta and the pulmonary artery. And that muscle results into significant pulmonary artery stenosis. What the baby had and how he looks like now, he still has the 2 great arteries coming off the right ventricle. He still has the big hole in between his ventricular chambers. But now what they did is, because he had the stenosis in the pulmonary artery, the blood that was going to the lungs was not enough, was not able to evacuate the right ventricle appropriately. So they connected his superior vena cava directly to his pulmonary arteries. And now the blood from the superior vena cava bypasses the heart so that it goes straight to the lungs without having to go through the stenosis. And with that way, we achieve better saturation. What the surgeon wants to do, he wants to be able to separate the 2 circulations. So he wants to bring this very skinny pulmonary artery to the right side of the heart, to the right ventricle, and move on the aorta to the left side of the ventricle, and then close the ventricular septal defect. Just because our aorta is our most important artery, and the aortic and the coronary arteries come off the aortic root, what the surgeon does is that he takes the entire root, the entire aortic root, and brings it to the left side of the heart, and then uses the pulmonary artery or a conduit, if he can, as the right pulmonary artery. The most important thing is to make sure that the pathway, so when you close the hole, you leave adequate space to the left ventricle and adequate space to the right ventricle. So you do not occlude any of the 2 arteries. So starting from the belly, you see your IVC goes into a dilated right atrium. You see a smaller left atrium, and you see 2 valves that are different level. You also see a big VSD, and now a big artery that is the aorta is on the front, and a smaller size artery is on the back, and it's the pulmonary artery. You get a good size arch. I'm going to go through the same video. I'm going to let it play. So IVC, right atrium, left atrium, small size LV, big size RV, big VSD. And then as it goes all the way up, you have the pulmonary valve in the back and the big aorta on the front, and 2 good sized pulmonary arteries, branch PAs. Looking at the heart in detail, you can tell that the right ventricle is much bigger compared to the left ventricle. So is that hypoplastic left ventricle adequate for the child to support the systemic circulation in the future? We can quantify the blood in each of the 2 ventricles, and based on the quantification, either on the 4-chamber or on the short axis, This is the short axis where you see the VSD and FAS2. We come up with a number, which is an appropriate number. It's like 32 ml per meter square, so it is not prohibitive. For the patient to have a 2 biventricular repair. So this small LV, it looks small, but it's probably adequate. Then when we go back to look at each of the segments, like I said, this is the right atrium. It doesn't look as big as it looked in the previous image, but it is dilated. A smaller size left atrium, and then a mitral valve that instead of sending the blood to the left ventricle, it sends the blood to the right. So that's what we call a straddling mitral valve that has connections from the mitral valve to the crest of the VSD. So if the surgeon needs to separate the two ventricles, he will need to cut these cords and end up with an insufficient mitral valve. That's not a good option either. Then we use the 3D whole heart sequence to demonstrate the pathway between the VSD and the great arteries. So remember, that is the aorta that comes off the anterior ventricle, the RV. Behind the aorta is the hypoplastic and very narrow pulmonary artery. And between the two great arteries, there is this muscle that is the conal septum. It's demonstrated on the second picture as well. And you can see that if you put a patch at the bottom of this conal septum, all the way to the crest of the septum, then you're gonna exclude your pulmonary artery from your RV, and you're gonna end up with a very small sized right ventricle. At the same time, when you see the tricuspid valve, you don't see the main pulmonary artery at the outflow, and you encounter the aorta. That means that the vessels are very displaced, and the surgeon is gonna have trouble. On your 3D whole heart reconstruction, you do see the parallel course of the two great arteries, but they look transposed basically, and you appreciate the same relationship of the bigger aorta and of the anterior wall of the heart, and the small size hypoplastic and narrowed pulmonary valve in the back. This is the AP relationship that it's favorable for translocating the coronaries. To demonstrate the coronaries, these are important information to the surgeon, and you also demonstrate the pulmonary arteries and the Glenn shunt. Remember the image that I showed you with the superior vena cava that is connected to the branch pulmonary arteries. Here are the branch pulmonary arteries. It works quite well. There is no thrombus, and the whole system works fine. Here it is again, superior vena cava, right and left pulmonary artery that are also in contact with the main pulmonary artery. And at the end, you demonstrate the aortic arch. Through 4D flow, we do extensive calculations, and with those extensive calculations, we need to assess the amount of blood that goes to the lung and the systemic circulation. And if there is something that is not equal to what we are supposed to have, that means that we may have also collateral vessels that we need to take into consideration, so extra sanding. To conclude, this patient has a left ventricle whose size is not prohibitive for using it to support the systemic circulation, has a favorable anterior-posterior relationship between the aorta and the pulmonary arteries that is promising for coronary anatomy and root relocation. However, the VSD pathway may not leave enough right ventricle and exclude the pulmonary artery from the right. So we did end up doing a 3D printed model. The straddling of the mitral valve is also very concerning because, like we said, what if the surgeon cuts those cords and the patient ends up with severe mitral valve regurgitation? There is nothing to be done on a small-sized 3-year-old patient at this point. And we also need to calculate the collateral burden with cardiac catheterization and assessing pulmonary vascular resistance also before. So that was a very high level of complexity case. We need to take into consideration, in addition to imaging, our genetics, infectious disease, pulmonology, neuro, in order to come up with a pre-procedural planning. And that pre-procedural planning involves not only the surgical component, but also the rehabilitation and the long rehabilitation and recovery process. And this is one of those patients who's going to need long-term surveillance, and probably the next speaker is going to talk about that. But having all of this information in mind, my conclusion would be that, first of all, with congenital cases, you need to know very well the patient's medical history, and particularly the prior surgical history. Try to choose the best non-invasive and most informative diagnostic technique. That's not the MRI in all the cases, but MRI can offer a multidisciplinary assessment, not only for anatomy, but in terms of volumetry and physiology of the patient. Start with segmental anatomy in order to avoid all the accumulation of abnormal connections, and do follow the same process with calculating QPQS, following the guidelines and the images that I showed earlier and are available to everyone. And keep in mind that a simple lesion can become a complex lesion when you have coexisting conditions. And that's all I have to say, and I'm here for your questions. Thank you very much.
And
thank you very much, Dr. Kourtidou.
I don't know if there are any questions from the audience. Otherwise, I have a question. Do you think that in like simple cases like an ASD, nowadays that actually sometimes surgery is performed not through middle sternotomy, but thoracoscopic surgery. Do you feel that it may be necessary in most cases, especially these that we cannot identify all pulmonary veins from the echo, that we perform an MRI before? Because I think that during this thoracoscopic approach, the surgeon is not able to identify all pulmonary veins. How do you feel about that?
So I think it depends. So if you have a small child and you can appreciate at least 3 of the pulmonary veins, and you can definitely see the 2 right ones, I'm not sure if I would go for a CT or an MRI right away just for a small size shunt. But I would discuss it with the families, I would be honest. At this point, if we need to sedate and occasionally to intubate, I'm not sure if that it works the effort for a small size shunt. However, I do believe that in the next 5 years, with the sequences that are going on right now and they are being studied, the 3D whole heart, like 5D whole heart, it's going to be like a 3-4 minute case, and the kid is going to be able to stand still for such a small amount of time, and I would definitely do it. But right now, it's very complex, and I do share the same concern, sending the patient in the OR without giving the full picture to the surgeon. So I do discuss it with the families.
Yeah, thank you. Because actually, most of the time, thoracoscopic surgery is actually done in more than 20 kilo kids. So maybe they may not really need to be sedated at some point. Right?
But in general, like for thoracoscopic, if they don't need to be sedated, then I would go for it, just for the MRA, not the MRI necessarily, just for the MRA. If you have a targeted question, then the study is a quick study. It can be a 15-minute study for us to answer the question about veins, or it can be a 15-minute study if you want us to answer the question about QPQS. But if you want the whole thing, and if it's a one-stop shop, then it can be as long as 2 hours. That's why it's not patient-friendly. But I'm very optimistic about the future. I think AI is going to bring an exponential growth.
Great.
Congratulations anyway. It was a great case and you did super work. So we enjoyed so much.
Thank you. I enjoyed being among you. I really.
Yeah.
Tanya, can I ask, congratulations from me as well. It was a very nice presentation. Can I ask you a question? I saw that you use a lot 4D flow. Do you use it for clinical purposes, for research purposes? Do you find it superior compared to conventional technique of phase contrast, and in what way?
Yeah, so I feel more confident now that we have guidelines on 4D flow. And I may end up using some of the data like for report clinical information, but I'm not brave enough with the pediatric population to give up on the 2D, like to the phase contrast, the 2D phase contrast, the traditional assessment. However, what happens is just because sometimes the kids are done in the middle of the examination and I don't have the time to take all the flows single by single, like one after the other, I may end up, telling them, okay, just watch a movie or just listen to the music and I'm going to run 15 minutes for the flow and use the data. But I always try to get ascending aorta and branch pulmonary arteries no matter what. So I have the ascending aorta and the branch pulmonary arteries, and then if I need to have more dedicated flows like pulmonary veins, I will probably run the 4D flow at the end. And then I know that I'm done. They're not going to let me do anything more.
Yeah. Thank you. Thank you very much.
Yeah.
Okay. It's your turn now, or Pushparaja? Pushparaja sent his talk.